In diesem Video unterhalten sich Dr. Judy Mikovits aus Carlsbad, Kalifornien in den USA, Privatdozent Dr. Wilfried Bieger aus München und Professor Dr. Kramer aus Heidelberg zu der Frage Gabe von Rituximab bei Chronic Fatigue Syndrom. Disclaimer: The information in this website and the displayed videos is intended for general knowledge only. It is not a substitute for professional medical advice or treatment for specific medical conditions. You should not use this information to diagnose or treat a health problem or disease without consulting with a qualified healthcare provider. Please consult your healthcare provider with any questions or concerns you may have regarding your condition. So today we have a guest from the US, Judy Mikovits. Welcome. And Judy is working in the field of chronic fatigue syndrome since quite some years, and we are happy that she will join her or share her ideas and concepts with us. And we have a few questions which we want to have answered. And maybe, Wilfried, you start. You expressed a specific interest in in the use of Rituximab in CFS therapy, and there might be some specifics that we need to address before you use such a drug for therapy in CFS.
Yeah, we have you know that we in Germany there is some efforts to use Rituximab, and as far as I know, there are 10 patients in Germany, and 8 didn't get any benefit, but they didn't suffer.
Okay.
And 2 had no benefit but suffered.
Okay.
So this is, and then they stopped it to recommend it in Germany.
Okay.
But nobody knows, I think, when to use or why to use even. So what is the idea? Of course, there's a rumor that at least in Norway they have success, and they think that CFS is an autoimmune disease. And I think I heard that some thinking that there might be antibodies against neurotransmitters or against neurotransmitter receptors, catecholamine receptor, epinephrine receptor, and so. So, but that's the only thing I know. I don't. I only know the patients who had no benefit, or even now I'm working with the one who has who suffered most. Yeah, and it's funny here. He explained that when he got only 1 injection,
Okay.
and he became absolutely clear
In his brain.
but physically he deteriorated, and now he's so. And then, within a few days, he became so weak that he hardly can stand up.
Okay.
That's a situation, and now we have to see
We
what we make out of this
maybe,
case.
maybe you know more.
Yes. Well, I do know more because I had the pleasure of working with Drs. Fluga and Mella when they were first showing some of their preliminary data back in 2010. And what we were studying and they were studying at the same time was the innate immune defects. So we had also data that showed that certain patients, it's the problem with ME/CFS is it's a very heterogeneous disease with complex system patterns of problems and overlapping patterns of problems. So it's not only the B cell. So many of the patients had B cell defects. So what we saw was early on is that the patients would come in and they would have subclass deficiencies. So if you do a test, Dr. Bieger, you say you have low IgG, you have low antibodies, and you have subclass deficiencies here. But when we looked at the total B cell compartment, the numbers are the same. So we're saying what's happening? Well, what was happening is those patients were producing precursors to the plasma cells. And those are cells that see if I can show you the next slide. Those are cells that have CD23 and CD20 instead of the CD19 plasma-producing cells.
Yeah.
So Rituxan targets CD20 cells.
Yeah.
But and so if those are hyperproliferating in the absence of CD19 plasma antibody-producing cells, then what you have is autoimmune disease. So it's that CD20, CD23 cell. So we summarize the data that we did in lots of populations, but just to talk about that one, is that the presence of these cells, they're autoimmune. The antibodies that they're making are against self, as you described. Maybe catecholamines, lots of other things. Nuclear proteins, mitochondrial proteins, which are, of course, self. So those cells are then creating an autoimmune disease. They're making cytokines that are furthering the problems and not ending up as differentiated plasma cells. So what Rituxan does, and this cell will eventually, see if I have yes, I do. So what we found early on is if we took peripheral blood from CFS patients and we put them in culture, we just put them in the incubator and grew them, what would happen is that cell would grow out. That CD20, CD3, it would just grow on its own, immortalized. And eventually that would become a tumor, a chronic lymphocytic leukemia, if your natural killer cells didn't see it and kill it. So it has to be seen as a tumor cell or a virus-infected cell for your natural killer cells to see it. But ME/CFS patients have problems with their natural killer cells. So that innate immunity is greatly decreased or gone. So these cells are allowed to grow. So in 30% of the patients, we could grow these cells. Those are the 30% that should get Rituxan. But they should only get it at low dose.
Why?
And they should get, because the dose for a cancer is way too much. Because if the cell co-expresses CD19, CD20, CD19, CD23, then you're going to take out your ability to make antibodies further.
Yeah.
So that's why I think your patient is sick right now, because it was too high a dose.
It was certainly too high, and he's even after 1.5 years, still the B cell number and the CD20 number was extremely low.
Correct, because he has an ongoing underlying problem that hasn't been cleared by the Rituxan. So what Fluga and Mella showed in the patients that had benefits is it would last about 3 months. So they'd do one injection, let it go like 3 months, and then the disease would come back. And they'd come up again, and you hit them again. Well, we were doing this in chronic lymphocytic leukemia. We were doing it in mantle cell lymphoma. We were doing it at the same time when I was a cancer researcher. And we used to give it at the same time we gave highly cytotoxic, highly damaging chemotherapeutics like CHOPs and MOPs and things you might know of. Those are the designations of the chemotherapy. But what some of the older patients who had a low level of disease, something that was just smoldering, they would call it. And normally we watch and wait on that disease if it's not gonna kill them right away. But what I found with those patients was we convinced their doctors, just give her the Rituxan. And just give her one dose, lower dose. And
would it be the oral? Now you have your low dose oral Rituximab you can get?
Just Rituximab alone in saline, very low dose, very slow infusion, or even...
You said oral?
There's a new oral
Great.
Regime,
So you can use it orally. That's great. And just do it low
much
dose.
lower dose.
Much lower dose, because you're going to take, these cells aren't growing very fast. They're very, very slow. So you only really need to kick it. And then when the disease comes back or he starts worsening, give him again. So you don't give it every day, and you don't give
Would you get a lasting effect finally?
That remains to be seen. Because you have to clear the problem. So you have to find out what's disturbing the bone marrow, which of course we think are retroviruses.
So the diagnostic procedure will be looking at the
CD20 population.
23 cells.
CD20,
and
CD23.
If they have
yeah.
Expanded.
If they have expanded,
that's
do
right.
low dose. If they haven't expanded, don't do it just because they've been called.
But is this what they
CFS.
did in Norway? Did they look at this population? No.
I don't know the answer to that. We have their paper here, so
Because
this
initially
is their
they
paper.
just it was
They just
it
gave it to
happened that they had
patients,
these patients had Hodgkin lymphoma. 3 patients,
Yeah.
the initial 3,
Correct.
and they treated the lymphoma,
Correct.
and then
And they got better.
fatigue went away.
And of
but
course
was it really chronic fatigue or was it just tumor fatigue?
Well, of course, that's
what I feel.
that's what happens. I mean, and in fact, we think they're different sides of the same coin. So we think that it's a subclinical to frank disease. So your immune system can kick in at any time and prevent you from developing the cancer. And of course, when I went to Dan Peterson, first saw CFS-ME patients back in 2006, it was the ones who were developing the cancer. So I walked in as a cancer research and cancer drug developer to provide, and so I don't see them as different disease. I see them as progression along a disease symptomology. So that's what you're looking at. And so some of these patients will go on to develop CLL, chronic lymphocytic leukemia, mantle cell lymphoma, non-Hodgkin's lymphoma, some of the T-cell
Is there evidence
diseases.
of that?
Yes. See this bottom paper? See this bottom paper by Eric Engels? That's an epidemiological study that was published in 2011 or 12. And what it said was these patients are developing cancer more when they have the chronic fatigue syndrome. So you don't have to know why. You just have to treat, fatigue was always one of the warning signs of cancer.
Yeah.
But if the cancer doesn't develop, and the fatigue is crippling, you need to look further at the immune system to see what's not functioning. So I think it's the combination of the natural killer cells not recognizing the B cells, so the Rituxan does the job the natural killer cell's doing. But and in some of the patients, Carmen's work, you mentioned the German study, is that there yet? No, that's just these are other signatures. So in Carmen's study, what she showed was that EBV specific, see if I can see it there, lots for TGF-beta, was that EBV specific cytotoxic T cells and B cells simply weren't there. This is another test for CD57. So in a lot of these, if you want to ask if your patients who don't respond to rituximab, if you do the B cell test and you do this test, because if these numbers aren't low, then they've got their natural killer cell function, so the drug might be too much. And that's why they don't benefit, because there are other things going on. So this is another diagnostic test I think I'm looking for this paper. So this paper by Carmen, what she showed is these patients have deficits in specific populations of cytotoxic T cells and B cell immunology for people with chronic EBV. So you don't have your B cell antibodies, that's the ones Rituxan would recover. So when Rituxan takes out the CD20 cell, it allows the maturation to the plasma cell. That's the whole immunology of it. So you're breaking the cycle, but we haven't figured out what's going wrong in the bone marrow to stop the stem cell from getting to the plasma cell efficiently. And as you age, all of these immune things happen in aging. So I see ME/CFS in cancer, and of course HIV/AIDS and HTLV.
Premature aging.
Exactly. Accelerated aging. It's an accelerated disease process. Premature aging.
You mentioned retroviruses. Maybe since we're sitting here, you can make the point a bit clearer. Which role these retroviruses play in this whole picture?
Well,
because that was one of our initial discussions offline.
Well, and so what the retrovirus does, just as it does with HTLV1, And just as it does in, let's see if I've got all of that here. I do have a whole lot. There are a number of, we can talk about primary immune deficiencies.
Yeah.
But what retroviruses do is they create acquired immune deficiencies. So retroviruses tend to infect innate immune system, monocytes, macrophages, B cells, and they live there. And they integrate into the genome, means they stay in the genes of that cell forever. So every time that cell divides, the retrovirus divides. And it infects more cells, primarily of the immune system, because those are the only dividing cells other than tumor cells and colonic epithelia. So for your patients with gastrointestinal inflammatory bowel disease, they could have retroviral involvement in destruction of the gut immune system, which is a big part of your immune system, is there in the gut. So retroviruses create the immune deficiency. So they can either take out the B cells, the natural killer cells. They can modify the cytokine environment. They can modify the signals like they did with the B cell. They're well known to, in animals, to cause the very B cell deficiencies, plasmacytoid dendritic cell. That's the major 99% of your type 1 interferon, alpha interferon, is made by plasmacytoid dendritic cells. In patients with HTLV1 and XMRV infections, or cells with XMRV infections, they don't make type 1 interferon. One of the first things we found in ME/CFS patients is they don't make type 1 interferon. So the drug Ampligen bypasses whatever the block is in the plasmacytoid dendritic cell, which can be infected by retroviruses, HTLV1, and they cause similar diseases. So HTLV1 causes a myelopathy that'll put a patient in a wheelchair with muscle defects. So somehow those genes are influencing the mitochondria, and it's that immune deficiency created by the retrovirus that ultimately causes the disease. But HTLV1, I have a couple of pictures of it here, HTLV1 doesn't, this is the two diseases that HTLV1 causes. It is causal for adult T-cell leukemia. And what that means, that's a very aggressive T-cell leukemia. And that leukemia, every case of that leukemia has evidence of a HTLV1 infection. The cells are infected. They also cause, it's in the Caribbean and Japan, it's endemic with tens of millions of people infected. And it causes this, later we found it causes uveitis, eye inflammatory diseases, arthropathy, myelopathy. It puts the people in wheelchairs. And all they need is alpha interferon and AZT to reverse the disease process. And now this really aggressive cancer that they're talking cures by simply using AZT, alpha interferon, and decitabine. Well, what is decitabine? Well, it demethylates the genes. So it activates latent retroviruses. When you demethylate a retrovirus, it'll express it so the AZT can kill it. So one thought in ME/CFS patients where in our work, we found the retroviruses were latent in many of the cases. That's why now you see them, now you don't. So the controversies become, oh, they're not there, or they are there. Well, we learned with HTLV1 that only 5 to 8% of the infected population got any kind of disease. They just walk around healthy, because these are viruses that our immune systems, if we're healthy, we can take care of them. But if we have methylation defects, if we have co-infections, if we have RNase L defects, which are a hallmark of this disease, then, of course, you've got a problem. And the virus gets a little bit more of a hold, and it gets more of the infected B cells, and you don't clear the reservoirs, because in the dendritic cell, it's hiding in the dendritic cell, and the immune system can't see it. In HIV, we called it lipid rafts. So the dendritic cell talks directly to the cells, and it's never seen by the periphery, by the immune system. So you see the viruses create the immune deficiency. So you don't have to treat the viruses. You can shut down their expression easily with things like AZT was developed in cancer therapy. It wasn't developed as an antiretroviral. It's a chain terminator. It looks like one of the bases, and when you put it in there, it locks it up so the DNA can't be replicated anymore. So you're shutting down the bad transcription. And if you shut down the bad transcription, then of course you don't have microRNAs being made. I have a lot of slides here. So this is a talk about HTLV1, which Frank Rossetti and Kathy Jones did. And so these TLR antagonists, imiquimod, they can make the cells produce the alpha interferon again, just like Ampligen can. So these toll receptor modulators, which we've used in cancer therapy now and developed dozens of them. And so as you mentioned when we were first talking today, why not? The drug companies have pipelines of drugs, and there are millions of patients who could benefit from things which usually won't harm them. And if they don't hurt them and they don't harm them, then you can move on to the next thing. So you and we can create an algorithm for simple tests to do in patients. If not this, don't do this. Don't do Rituxan if you don't see those CD20 B cells as more than normal numbers. And then when you do it low dose. And I even thought, how about a nasal spray? How about let's not make it systemic? So it's the systemic that does all the toxicity. Protect the bone marrow with something like
But you need to get the cells in the bone marrow.
Yeah, you need to get into the bone marrow, right? But before they differentiate and get infected. So one of the reasons why Paul Cheney and I were several years ago thinking a lot about stem cell transplants in these patient populations, but we don't want to do it if we haven't silenced the retroviruses. Because if the retroviruses aren't silenced, then the new cells will get infected. So you can put in the good cells, but sooner or later, and then you'll exacerbate the disease because you've got more. Because they're very, very, very slow growing. The thing about the gamma retroviruses and HTLV1, very, very, very slow growing. The immune system does a very good job to keep it down. And you need something else to start.
Is there a diagnostic approach towards this retroviral load? I mean,
one thing you can look for is reverse transcriptase. Many, many, many studies in multiple sclerosis, in Sjogren's syndrome. I don't say that right according to the Swedes. And diseases that look retroviral, ALS. ALS always has reverse transcriptase. So what people try to do is they try to isolate the virus, but you don't really have to do that. AZT is a broad spectrum reverse transcriptase inhibitor. And reverse transcriptase is only made by retroviruses. Integrase, the one that opens up the DNA and puts it inside your DNA. So Icentris has been used in some multiple sclerosis trials lately.
This is the integrase
That's the integrase inhibitor, and that's a no-no. You can't use it alone. Because what do you have if you have DNA and retroviruses being made and they can't integrate? Well, you're going to create a cytokine storm of unintegrated DNA in cells is a very bad thing for patients. So if in ME/CFS somebody does an antiretroviral trial, you can't use integrase inhibitors alone. And what we do, the community that had treated a number of these patients with retroviruses before the antiretrovirals, before the controversy, is we start with Viriad, Truvada is one of the trade names, or simple AZT. But AZT causes more toxicity, so you have to use that low. So that causes more kidney and liver toxicity, hematopoietic bone marrow toxicities. So you have to be really careful because the kidney is one of the reservoirs of the viruses. Retroviruses like kidneys, because of course that's what filters things through. These retroviral sequences were found in urine, so they're often found in urine and things, and they're quite stable. So you want to be really careful with the kidneys of the patients.
So when you
and
say
do a lot of testing.
don't treat with a retroviral,
Antiretroviral if they have. I wouldn't use,
I
wouldn't use
think about
AZT.
the combination.
I would use a
different
combination.
Retrovirals.
Yeah, different I would use a
Not the-
combination.
You meant not the integrase.
It's not the integrase inhibitor, but the RT inhibitor you can use alone anytime.
That's
The problem
no
is that,
problem.
that RT would then produce
Like
the virus
yeah.
without integrating the DNA.
Yeah, and
then
that's a problem.
overloading the cell with free DNA, which would then be a
Is a signal
strong
for
inducer
cytokine.
for
Yeah. The very,
cytokine production.
the very thing you don't want to do.
And is there really a kind of one could have an antibody test against a certain protein which is common to all retroviruses?
Well, it's common to gamma retroviruses,
Yeah.
so you could certainly do an antibody test for reverse transcriptase. Every retrovirus, by definition, they use reverse transcriptase to take their RNA genome, make it a DNA genome, and insert it into your genes where it's expressed.
Yeah.
So that's where the reverse transcriptase is.
And that's
It
to
writes
prove
it
that they're
backward.
active.
And that proves that they're there and active, correct. So if they're not active, they're not a problem.
Yeah.
If they're,
Yeah.
not initially.
Yeah,
If you can keep them latent, that's fine. And you can yin-yang them with decitabine, the methylation inhibitor, because that'll hold methyltransferase and allow your the virus to be expressed. And so I have some papers, and on our website at Mar Consulting, you'll see my full CV and Frank Rossetti's full CV. So there's hundreds of retrovirus papers and lots of methylation in both HIV, HTLV1. So you can sort of see the kinds of data like I'm showing you here from Frank's work, where imiquimod, the TLR7 agonist, I think, is therapy for HTLV1 induced problems in plasmacytoid dendritic cells. So if you have a person who responds to Ampligen, and maybe that is an infusion drug, that could easily be a nasal spray. I've talked with the company. I'm not sure why they don't go that way, but that's a drug. So drugs that were beneficial in HIV, AIDS, and HTLV1 associated inflammatory diseases and cancers are ones that should be tried in ME/CFS and associated diseases where there's evidence of retroviruses. And there have been evidence of retroviruses described since Elaine DeFreitas in 1991 published the papers with Paul Cheney and David Bell's cohorts where there was clear evidence of retroviral problems, papers with ALS and RT activity, lots and lots and lots. Lots of papers where it's simple
Is there
to
any
do the
therapy
test.
done for ALS with antiretrovirals?
Not that I'm aware of. They may have started clinical trials lately, but not that I'm aware of. There seems to be a block for if they can't identify which retrovirus. I'm of the who cares if it helps them, and of course your benefits. If it's not going to hurt them and it has the potential to help them with a logic for doing it, why not?
Then should try.
And
because
you know your patients
there's no solution to
who
that.
asked you for
These
that.
patients die.
Yeah. And but our patients don't die, but they live. ME patients live a horrible life that they might as well. Suicide is usually the form of death because there's no quality of life if as your patient can't walk, if they can't get out of bed, if they can't think, so.
One question concerning RNase L. You mentioned this enzyme. What is its role, and what? I mean, there are mutations in RNase L which can be found, which obviously result in low activity.
Correct.
So what is the status or the position of this testing in your concepts? I mean,
So RNase L degrades nucleic acids in the cell. So anytime it sees what looks like a virus sequence, it'll do double-stranded DNA as well. So double-stranded sequences. That's why poly-IC poly-IC that we use, that looks like viral sequences, in cells. And so it stimulates type 1 interferon production in people who have a block or people who have a defect. And so if they have a defect in RNA cell, we say you don't want to do that because you could do more harm. So we know that ampligen and some of those things do more harm. So it's a key enzyme in the type 1 interferon, which is probably your key innate antiviral defense. And RNA viruses, the flu virus, West Nile virus, Ebola virus, HIV, HTLV1, they're all RNA viruses. They're not all retroviruses, but of the emerging infection in our world today, of the last 50 viruses discovered, 49 of them are RNA viruses. So if you don't have an RNA cell pathway, so yes, the genetic defects, the single nucleotide polymorphisms are associated with reduced enzymatic activity. So it doesn't work as well. And so if they're autosomal dominant defects, then
so
you
that would
inherit
make sense to set such a test.
Correct. So you can do, all you have to do is look for the published variants in the genome, and with the sequencing of the human genome over the last years, a number of companies have come up and they've put 1,000 genes together or 15 genes together or proteins together and said, okay, this is the level of your aggressive, I know it in breast cancer or prostate cancer. We do Oncotype DX tests. And what that means is, okay, you've got a cancer. What's the gene expression like in these 4 categories of cells, of genes? And so if you have no problems with all of these, they don't do really aggressive therapy because you're not likely to ever see the tumor again after you do the surgery. Or they do just low-level radiation therapy or something else. So we can design this for the ME CFS patient. And we can look for RNA cell defects. We can look for channelopathies because those have been described in those patients. That means their calcium and magnesium ion transporters don't work well.
And they have antibodies against part of these channels, or?
No, they just simply don't function. So the channel won't open up.
They are at the genetic level.
They are at the genetic level.
Okay.
And so their susceptibilities, because you almost have to have the perfect storm. So that's what the data that I put in here recently, because of all we know about genetic testing and expression, is this called X-Men, is a new primary immune deficiency. And what it was a magnesium transporter. So that magnesium transporter didn't work. And when it didn't work, this NK receptor that's called NK2G, which we know the NK cells of CFS patients don't work. And look at all the symptoms that this guy has. This guy could easily be your patients who don't respond. And so it's not the B cell that's their problem, it's the NK
have
cell.
other problems. If he can handle magnesium properties, he should have other problems
Correct.
too.
Lots
But this
of other
guy I'm working with, he was a great sportsman.
Right. Until his mitochondria couldn't function anymore because of all the interactions with the mitochondria. So what this says, or the NK cell, so what this magnesium loading does is this is literally like a cannon. And so it's the NK cell kills the virus-infected cell in the tumor cell when you reload the cannon. Well, if you have this channelopathy, you can't kill. Even if your NK cells are there, they don't work. So you see, people could say, well, my NK cell number is fine. Yeah, but they don't kill. So you look and so you can
do anything there?
Yeah, you treat with magnesium threonate. Not any magnesium, magnesium threonate, because that crosses the blood-brain barrier.
This is really the one which is so good?
Yeah. So in here, it's this paper, here's the reference.
Magnesium threonate.
Because it crosses the blood-brain barrier.
Is this the only one?
No, there are some others with amino acids linked to the magnesium. It can be other ways of link. And so what I'm showing throughout this slideshow that I gave earlier this year is that we don't need to start from A, have a cause, in 20 years of drug development to have one drug and have a cure. We have lots of drugs in associated diseases. If we just think of those diseases differently and take the evidence of what the immune systems of these patients are telling us. And they're telling us a lot, and we've done a lot of work over the years, and it's just a matter of looking at the data differently and bringing in, you know, people who, I look at cancer and AIDS, I look at acquired immune deficiencies, and from the day I saw ME patient in late 2005, I said, this is an acquired immune deficiency. And that's how I think of it. It's acquired. Doesn't have to be HIV, doesn't have to be HTLV, doesn't have to be a retrovirus. But whatever has, you acquire it because you have an innate, some susceptibility. So there's something wrong. And those susceptibilities were heterogeneous, you know, we're not inbred mice. So finding these things took the 2003 sequencing of the genome.
Yeah, that's a very good statement, I think. I think we disregard it because if it is a disease like that, it's going on very slow.
Correct. It's very,
and
very
therefore
slow.
we like to
So by the time the patient gets to the doctor, that's why the very first or second slide in this program, this is how we think of disease. It's a disease engine. So it's very subclinical here. It takes 20 years to get to a tumor. The latency of even HIV that we learned later was, 10, 20 years before your T cells are so low, and only 1 in 10,000 T cells was ever infected with HIV. So we quickly learned it was the monocyte, it was the innate immune response. We didn't quickly learn it, we didn't learn it until 1991, and we isolated the virus in 1983, I think, something like that.
83, I think.
But it takes a long...
Because 84, I remember that we started the first test with infected cells, immunofluorescence test.
I was at the Army service and the first ELISAs came out, but the start was infected cells. Anyhow, thank you very much. I mean, it's interesting and motivating to listen to you. And what I suggest is that you possibly can give us your talk. We should prepare here, and we will record it, and we will put it on your website. So people can listen and can have their own idea, develop their own ideas. Thank you very much for visiting us.
You're welcome. It's a pleasure always.
Yeah, thank you.
Vielen Dank für Ihr Interesse. Weitere Informationen finden Sie unter www.dr-bieger.de. Haben Sie Fragen, Anregungen oder Kritik? Dann schicken Sie uns doch bitte eine E-Mail an praxis@dr-bieger.de.